afternoon. Okay, my name's Meyer. I'm one of the consultants at the Robert Jones and Agnes Hospital, and I'm going to tell you about the Veterans Orthopaedic Service. So I'd like to quickly take you through the history of the service, tell you about our data, how we interact with defence, some of our current issues, future plans, then end up with a sort of conclusion. So we started off in 2013 as a means of providing veterans with holistic, high-quality orthopaedic health care. That was our idea. And in terms of where we sit, we're, of course, members of the VCHA who provide us with guidance and support. We've got some core aims. We aim to provide the gold standard services at Oswestry, make them available to veterans through a military-led team, whilst also providing welfare. We're the first service of its type in the UK, first to provide simultaneous welfare services, and we're easily the largest. But the thing we're most proud of was getting all of this to work within an NHS framework. We don't get any external funding or support. The demand for services has been so high, we raised money for the Headley Court Veterans Orthopaedic Centre. This is effectively an extension of our outpatient centre, but it's laid out and decorated in a way that veterans and military personnel recognise, feels familiar to them. If your patients have confidence, they will do well. And that's true for veterans, it's true for all patients. So downstairs, it's mainly an outpatient area. At the heart and soul of the building, though, is the Veterans Hub, where our welfare activities take place. Upstairs, multidisciplinary team rooms, simulation suite, training rooms, offices. Looks pretty good. We had a wonderful day last year when the Duchess of Edinburgh opened the building for us. So in terms of clinical services, our ultimate aim is to make all of these specialist orthopaedic services at Oswestry available to veterans. Now, I started with hip and knee because that's what I do. We rapidly expanded our services, particularly to involve sports knee and sports shoulder, but as you can see, foot and ankle, upper limb. We've now got veterans rheumatology. We also see a large number of serving personnel as well, and I'll come back to that. So this is really confirming what we've also heard from the Women's Hospital at Liverpool. We've got large numbers of veterans within our hospital community. And as soon as we declared ourselves as providing a veteran service, they actually were happy to say that they were veterans too. And we've got, surgeons, nurses, physiotherapists, the entire clinical group is helping us provide this effort for our veteran population. And it's important to say, it's not just the clinical staff. We've got strong support from our service managers, our performance managers, the admission staff, the clerical staff, medical illustration, and we've got extremely firm support from our chief executive and the board. And that's really what's allowed us to progress so quickly in such a short period of time. Referrals come from all over the UK and from worldwide. You have to have an NHS referral because, as I said, this service purely works within the NHS. Data. Again, we've just heard, data is difficult. The only patients we can say for absolute sure are veterans are the ones that come to see me and my team. So this is data just for hip and knee patients. As you can see on the graph, we see about 2,000 patients a year, even accounting for COVID. In terms of what those bars represent, that's our new patients, follow-up patients, and all our theatre cases added up per year. And that's over, since we started end of 2013, 20,000 patients. The welfare team, they started keeping a tally of their cases in about 2017. They're on the best part of 8,000. Just this year, they've already seen 1,600 veteran contacts in the welfare hub. So it's a large number of patients. And it's important to state, this does not include all of the veterans seen by the other 22 consultants that see significant numbers of veterans in our hospital. As an outside guess, we'd say certainly over 35,000 if we had all of the data for those patients. However you look at it, it is a very large number of veterans are passing through our hospital and receiving treatment. We need to appoint new consultants. Now, that's the clinical side of things. The welfare side of things, I think, is the most important part of the service. What lifts us out from just being a clinical service. It's what makes us really different. Now, our welfare services are run in conjunction with Shropshire Council. I say in conjunction, they run the welfare services. It's a real collaboration between us and them. Mrs. Sarah Kerr is over there somewhere with Sean from Shropshire Council. They provide, or she coordinates the welfare activities in the trust, and she links in with the service charities, people like Op Courage, Defence Welfare Services, and so on. We have 22 veteran volunteers. They have lots of roles. They see patients when they come into the hospital to direct them to the right destination, but importantly, they see people on the wards. That's really powerful. Being in hospital can be lonely, can be intimidating, quite frightening. Having someone come and see you, maybe bring you a toothbrush, newspaper, cup of tea, something like that, is really important. It's enough to change their experience from a poor one to a very good one. And importantly, they're not doctors, they're not nurses. The volunteers get told things they wouldn't tell us. And again, that's really beneficial as well. Another important thing to say whilst we're on this, of course, we see large numbers of serving personnel. If anything, the serving personnel need visits from the volunteers more than the veterans. Serving personnel, they still think they're young, they think they're indestructible, and then they find themselves in hospital. And they're just as deserving of the support as, of course, our veteran population. Okay, the welfare team also project outwards. They've got an outreach program, education program, and that all helps spread the word of what we do as well to our surrounding community, who are also extremely on side. Where do we sit with defence? Well, we don't draw any distinction between whether you're serving or whether you're a veteran. It's one big family. It's all the same group of people. Certainly, we are seeing more numbers of serving personnel. And that fits in very well with our veteran service. It's good for our veteran patients to see serving personnel within the hospital. It's also good for the volunteers. So looking after them as a group really makes sense. We've always provided rapid services for Hereford Garrison, which is just down the road. We also see overseas patients and dependents with the global medical team and so on. You know, we're currently negotiating to try and do more work for defence in this sort of fashion. Whilst we're on that, we have a very close relationship with 202 Medical Regiment. Of course, Professor Briggs is our honorary colonel. Miss Warren, who you're going to hear from shortly, is one of our enhanced recovery sisters. And having reservist personnel within the hospital providing support and treatment for our veterans and serving personnel, of course, they have a better understanding of the needs of these patients, that it all just makes sense. And we'd like to employ more reservists into the hospital to be carrying out this sort of work. So it is not all good. So our greatest achievement was making this work within an NHS funding model. Our managers took a lot of time to get that right, and it's worked well for a decade. But things change. Last year, NHS England effectively withdrew our funding. Now, of course, they didn't do this on purpose. It was inadvertent. The NHS had been put in a meltdown by COVID, and as part of restructuring, call it what you will, they targeted what we call low value activity. They targeted referrals that come into a hospital from outside of its catchment area. Now, for a lot of hospitals, that's not too much work. But for us, 60% of our veteran workload comes from outside the area. So we were disproportionately affected. Last year, we were underfunded by about £1.5 million. By the end of this year, if we don't get this resolved, it'll be a further £2.5 million. £4 million worth of underfunding in 2 years. That's not sustainable. Now, we, of course, raised this at a national level immediately. Our finance officer spoke to NHS England. Our chief executive spoke to them. I went down to see the then Veterans Minister, people from the Office of Veterans Affairs. We even had a question asked of the Prime Minister at Prime Minister's question time. But no support was forthcoming. It took Professor Briggs acting as our, well, honorary colonel for a start, and of course our VCHA lead, to put pressure from his side for us to get any sort of resolution. And it's not resolved. We have a temporary fix which allows us to keep working. That, of course, has affected our future. We had plans for 2 veteran consultants to start. That's had to be delayed. This is a big aspiration. A National Veterans Rehabilitation Centre ties in with everything we've been hearing about rehab today. That's had to be put on hold as well. We had employed a national fundraiser for 12 months to scope out how we'd raise money for that, but that's had to be delayed. And it's also delayed the progression of clinical services. The one we particularly want to get going is a Veterans Paediatric Service, or Veterans Paediatric Orthopaedic Service. Military families, they're constantly moving every 2 years. Again, we heard from the Women's Hospital, and we heard from little troopers about the difficulties that military families have in general, but particularly if you have an orthopedic problem that requires, say, orthopedic surgery. Having somewhere where there is continuity of care, people know who you are, that is a useful thing to have. So what's particularly frustrating is we've just had D-Day, where we've heard about the debt society owes to the veteran population, that there should be more services, better services, greater collaboration of services. If you listen to what you see in the press, there's talk of priority care and dedicated services, but it's a lot of words. There needs to be more. Certainly where we are, when I spoke to the chief executive last week, she said, this remains a major financial issue for us, or a major financial risk for us. What was very reassuring, though, she's not military. She doesn't come from a military family. She's not served either. But her point of view was, this is extremely important. And she was very firm in that we will continue to treat veterans because it is the right thing to do. So where does that end us? Despite all of these problems, we provide an exceptionally good veteran service, importantly, that works within the NHS guidelines. What's more is we have a lot more to give. We've got plans to expand our services, but what we really need is central support. We need confidence that we're not going to have the rug pulled out from under us again. I certainly think there needs to be more focus on veterans initiatives further around the country. Having said all that, it is an extremely rewarding job to do. You know, just this year, I've dealt with patients who served in Korea, Falkland Islands. I've even had somebody who jumped into Suez, which was last time we did a combat drop. That is unbelievably rewarding to hear about those stories firsthand. And I certainly wouldn't be doing anything else. Thank you very much.
Yeah, just to start off with a little bit about me. I've just spent the last 18 years as a reservist in the army, and that's gave me the skills that I can transfer in my NHS role, which has been absolutely, valuable in my position as enhanced recovery lead, which is my current role, which I've been doing for 12 months. Being in the army has given me resilience, and when I need resilience to try and convince 24 orthopaedic consultants that enhanced recovery is the right thing to do, comes in handy. So VCHA, we was accredited in 2018. So we were the exemplars of giving the best care and support for our armed forces community. As a Veterans Aware Trust, we have been committed to deliver and support the best care for those who have served, those that are still serving, and the armed forces community. So I'm going to talk to you about enhanced recovery pathway, which aims to ensure that the patients get the very best care prior to surgery, receive the best care whilst in the hospital, and receive the best care whilst recovering. We've had lots of support from VCHA and GIRF. They've set the standards and provided us with the best practice and the guidelines from the decisions, one being the matrix of the length of stay. Now, I work in a hospital where everyone wants to stay longer because it's number one for food, number one for cleanliness, and number one for consultants. So I think I actually had the most difficult job to do. But being a member of the VCHA has enabled us as a hospital to share and drive the implementation of best practice, which is what we've done. So I'm going to talk a little bit about the pathway. So firstly, Joint School has been absolutely instrumental to the process. This is where we give our veterans all the information that they require prior to their surgery, and everyone wants to know what's going to happen to them. So this has been vital in the journey. We've looked at our anaesthetic protocol, which again, we've heard lots of times today that veterans have needs. One of them, could be communication needs or could be suffering from PTSD. So we need to provide a specific pathway for these patients. And as you can see here, this patient is quite comfortable having a knee operation while watching a movie. Another aspect that we looked into is optimizing the nutritional status. I learned this from the exemplars in Exeter, how vital it was to give our patients pre-op and post-op drinks, especially vital in the mobilization part. Mobilization has been absolutely key for our success in enhanced recovery. This is something we weren't very good at Robert Jones. And the reason for that was mainly because it was only done by the physios. So we put in a process to ensure that every member of staff was confident and competent at mobilizing the patient. As soon as you get rid of that gown and get a patient up, they soon become a very different person and stop acting like a patient, which is what I don't actually want a person to be following a hip and knee replacement. This is just gives you an example of the time frame. So this is actually my nursing officer, Colonel Marshall, who had a hip replacement, and you can see him there in recovery, actually looking like he hasn't had any operation at all. So this was at 4 minutes past 2, and then just before 5 o'clock, he's up mobilizing again, looking like he's not had a hip replacement. I would love to stand here in front of Prof. Briggs and say that every patient goes home on day 0. Out of the 3,000 patients we've delivered enhanced recovery pathway to, and 500 of them have gone home on day 0. With veterans, it becomes a big challenge because they come from 4 hours, sometimes 6 hours away. So to enable a patient to go home on day 0 when they're ready at 6 o'clock and you know that they live 6 hours away, it doesn't feel the right thing to do. And you've just heard from the Colonel that our plans was to build our own rehab centre, which would have been ideal for this group of patients who live a long distance away. Sorry, just to mention, obviously, you can see in that slide that within weeks, our Colonel was back returned to duty. So enhanced recovery, there's 4 of us in the team, and what we would like is to visit every single patient, but that's just not possible, especially with the catchment area. But what we do, if a patient goes home on day 0, then we'll give them a call on day 1 and day 3. We will, whenever, visit them. As you can see in this picture here, our Colonel's visiting one of our patients, but that's just not possible. But we provide a service that if anyone does need to come back into hospital, then they can do. And we're available for our patients 7 days a week, 12 hours a day. Now, looking after veteran patients is different to looking after non-veteran patients or armed services. For me, I'm lucky because I'm in a position where I can relate to them, I can understand their needs. And what's really good is that there's lots of banter on the ward. So if you have RAF, Navy, and Army in one bay, you can just imagine the banter. And then you've got me and the Colonel coming in. And if a patient has done well, I'll wind the Colonel up and say, you know why the patient's done well? And he'll say, why? And I'll say, it's because he's not an officer or her. So this is just a typical day at Robert Jones. And again, for me, this particular day was 2 members of the QAs. So again, lots of opportunities to have a banter with the Colonel, who's RAMC. It's a real privilege for me to be able to be in this role because I can give back, the best care possible for these people that deserve it. When you're looking after a Chelsea pensioner, it just gives you that massive sense of achievement, and it's just a privilege to be able to do. Teamwork has been essential in the delivery of enhanced recovery, and it'd be wrong of me not to mention Mr. Graham and Mr. Thomas. The pathway that we've delivered is a surgical-led pathway, and without their support, I just wouldn't have been able to stand here today and share with you the great patient outcomes that we've achieved. So one of the patient outcomes is reduction of length of stay. So our length of stay at Robert Jones and Agnes was 4 days, and it is now 1. Now, I'm not good at maths, but 3,000 patients we do a year. So if you times that by 4 is 12,000 bed days. So if we reduce that by 1, that's 3,000 patients times 1. So that's 3,000 bed days. So that's a saving of 9,000 bed days. I think I deserve a promotion, but no one's given me one yet. And that's a saving of over £1 million. And that's not including the day zeros. For me, with the implementation of enhanced recovery, it's meant that no patient has had their operation cancelled due to lack of beds. So no patient since the implementation of enhanced recovery has been cancelled, which in this current time following COVID is absolutely important, especially when people are waiting so long. We've seen a reduction in readmissions and reduction in infections, and the patient satisfaction we have is really good. We have shown with the numbers that I've just said to you there how efficient and effective way of working this is. This means that we can do more than this means that we can do more now than we've ever been able to do before. It's equivalent to putting an extra lane in the M25 that we said today, wasn't it? But yeah, we're in a position now where we can do more, and I don't think any NHS hospital can say that they're putting 3,000 patients through a 22-bedded ward. We'll continue to work in collaboration with VCHA and GIRF. More recently, we've just been rewarded to be an elective surgical hub, and we've just had our veterans accreditation. Both have supported RJH with meeting the needs of our armed forces community to ensure better health and well-being. We are committed to providing the best standards of care to the military community based on the principles of the Armed Forces Covenant. Now, hopefully I've got across to you today my passion for looking after the armed forces community, but not all patients are great to look after. Hopefully you'll recognise someone in these pictures, Prof. Briggs, who is our honorary colonel, which again is an advantage to me, especially you can see on the far side where I've actually got my hands around his head, telling him how great Robert Jones and Agnes is. So, but jokes aside, I just want to thank you and your team for all the support they've given to Robert Jones and Agnes, because without GIRF, without VCHA, we just wouldn't be in the position that we're in today. And hopefully we'll continue to put your work into reality and you be impressed with what we've delivered.